You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast with me, Owen Walker. In this episode, we're going to be speaking with Nico Preston on the role of artificial intelligence within pre-hospital care. So what we wanted to do in the episode is really look at how AI is being embedded within the systems and processes, from dispatch algorithms to diagnostics to demand profiling. We're also going to look at the future of AI and where it might support patient care in the future. So to do this, I have Nico Preston with me. Nico is a scientist and paramedic with a background in health, technology and innovation. So he has 15 years of experience with complex emergencies, emergency medicine, infectious disease, natural disasters, supply chains, toxic drugs, and indeed a career spanning non-for-profit, academic, government, and corporate sectors. Welcome to the podcast, Nico.
Well, thank you very much. Thank you for having me.
It's an absolute pleasure to have you on, actually. So, Nico, I just wondered initially, could I get you to speak to your history with data management and indeed how important it is to sort of be a data-driven service when enacting change?
Sure. So I've been working with data in a professional capacity for about 15 years. But really, it goes back 20 years ago to my undergrad in math and biology, where I had a summer job working as a database administrator and really learned my chops chipping away at biological field data with all of its quirks. Through graduate school, I had the opportunity to do more of a deep dive into data and statistical modeling, and then eventually into postdoctoral programs where I built collaborative virtual laboratories for the global health space and connecting sort of environmental drivers with disease. Eventually, in the professional space, I became a chief data scientist. I've served that role with multiple organizations, analyzing sort of global health trends and supporting virus hunters. And eventually my journey led to kind of machine intelligence, where some colleagues and I set out to build a differential diagnosis engine to sort of read the world's literature and diagnose new diseases. So we then used communications among physicians to kind of train the model. And of course, a lot of that's a lot easier now. So it's an exciting time. But to your question about how important it is, well, I think it's imperative. I mean, when you dive into data, when you make decisions based on the evidence and the data, you can see the big picture. As paramedics, if we had our whole picture of the health of our communities from sort of our night shift, we might have a very different understanding of the underlying health conditions versus our colleagues on the day shift. And it's only when you kind of zoom out from your urban to your rural stations that you can get the big picture. And I guess the only thing worse than not using data for decision making is using bad data.
Yeah, gosh, that's such a good point, actually. And like you said, from a comparative baseline perspective, knowing, just fundamentally knowing the baseline of pathology that you're looking at, the baseline of data from any kind of given domain, really, allows you to establish sort of a KPI or indeed a goal or sort of standard. But like you said, until you've got this almost like this general audit and a shared situation awareness about where you are, it doesn't really make sense to have any wandering goals, really, because that really does establish the baseline. You've mentioned a lot in your introduction, actually, there, Nico, around working with differential diagnosis and panning out to looking at where clinical red flags and risk mitigation within differential diagnosis. Could I get you to speak to sort of some of the initiatives you're currently working on, because that is an absolute key initiative. Is that still some of the corpus of what you're doing now?
It is. It's literally a corpus. So I am working on large language models, and really it has been a decadal journey. I mean, when I look back at the first models I built, they were trained on emails among physicians in the infectious disease space. And from those conversations, from those dialogues, we were able to train a machine, in quotes, to recognize similar patterns elsewhere and pick up on sort of the early indicators of a disease of unknown etiology or an unknown novel emerging disease, which, a few years after the pandemic, you can imagine why that was such a focus. And it was very interesting work. But I'm now sort of taking that to looking into sort of the dark corners and edges of those language models. And I'm working on some programs with our rural physicians through the Rural Coordination Center of BC to think about bias in our language models and the information we use to train them, and trying to introduce sort of marginalized communities, rural communities, and sort of those who are being a little bit left behind by the advance of technology, and integrating their health concerns and socioeconomic determinants of health into the models. So that's a little bit on the modeling side. Alongside that, I'm doing some work on ambient AI and scribing and trying to reduce the burden on clinicians in note taking. But then I also recently, I guess, since you sort of transitioned from a pure focus on pre-hospital, I'm looking more at a healthcare scale metrics. So I've joined our provincial data analytics and research team to look across the healthcare system and look at how emergency and pre-hospital ties in with the emergency department, eventual discharge, and patient outcomes.
And I think that's key, actually, Nico, because like you said, it's it's good to de-silo some of this work so that there is actually transition and indeed communication between systems. I think fundamentally some of the riskiest parts of pre-hospital care are the transitions of care into established hospital care, just not even from a communication or transfer of data, but also just the fundamental transfer of risk to the hospital. So I think, like you said, the aligning systems and certainly systems that speak to each other, and indeed systems which can recognize that transition and hold some of that risk is fundamental. So you've mentioned a lot already, but the role of AI within pre-hospital care. One of the things I was really fascinated in my previous life was how AI sort of really integrates within lots of systems underneath the surface, which you don't even realize
Right.
it's working away in this sort of silent, in this sort of stealth mode. But could you maybe speak to the importance of and maybe the prevalence of AI pre-existing within pre-hospital care?
Well, I mean, I guess in a big way to put it in context, it's been over 80 years that we've kind of been playing with AI. We go back to sort of Norbert Wiener's work in Boston and MIT, running digital or mechanized mice through models. I mean, this has been in play for a long time, and big organizations like Shell have been making futures decisions based on machine models for a long time. But I think in pre-hospital, there's tremendous potential, very disruptive potential, hopefully in a constructive way. And like many industries, we're just starting to see the potential and risk. So pre-hospital to me is a massively complex health setting, often in an austere environment. And I think in that way, as a profession, particularly given the complexity and the emergency aspects of the work, it stands to gain a lot from recent advances in technology and AI. Our adoption of it is very much constrained by the operational challenges. So despite good intention and vision by our leaders, there's limited time to carve out space for planning and road mapping and research and experimentation, or even digitization when you have the next emergency around the corner. So I think much of the success of our systems as they stand globally in paramedicine are dispatchers, who I describe with much admiration as kind of the MacGyvers of the health system. So to kind of unpack that for an international audience like yours, MacGyver was a show in the 80s remade a decade ago where he essentially solved every problem with a Swiss Army knife. That's how I see a paramedic and a dispatcher. It's astonishing skill set, and I have a ton of admiration for my former partners and colleagues in that realm. But what we don't do is provide our paramedics and dispatchers with adequate technology, in my opinion. There's a lot of potential, and the profession is going to get a huge lift from the realized potential of computer-aided humans. So if you imagine making those difficult decisions in an alleyway at 3 a.m, but having an AI in some form helping prevent a patient safety incident, having a digital partner you can run your med decision by or your contraindications, or having a dispatcher help with routing a crew to the nearest emergency. I think really the big potential in my mind is kind of decision support, automation, and analysis with a human operator coupled with a machine.
Yeah, absolutely. And I think all those are actually fundamental to, so, and again, it's a support role. It's not taking over, but what it is doing is supporting and extending that level of capacity. Can we maybe speak to some of the areas which so currently there is AI algorithms embedded within certain aspects of pre-hospital care. Like you said, there's some subtleties around dispatch and dispatch prediction about where the next 911 or 999 call will be,
Hmm.
and there's modeling from previous data. Um, my revelation around AI was around cardiac anesthesia and speaking to other guests around
Mhm.
deep learning of AI in hypertension tracking and predictive tracking of hypotension from even just subtleties of baseline of diastolic readings that can inform clinicians, namely anesthetists, or of what's happening with the blood pressure, what is going to happen. And these kind of deep AI systems are already in certain diagnostic capabilities. We spoke before, and you've notioned to the potential for um, just for the extension of AI. Just it can affect not only differential diagnosis, but where do you see it around not only demand profiling, but supply chain issues, logistical
Hmm.
planning, and provincially mapping of scheduling. Can you
Mhm.
see the utility within sort of multiple domains?
Well, 100%. Not only see it, but I've seen it realized. Just a small example, like scheduling. That's a complex problem, and I think as a former unit chief at a station, trying to keep your crew happy and get everyone the shifts they need is a fairly complex problem. And so on many levels, that scheduling influences a lot about our job satisfaction, a lot about our mental health burden and other aspects of this trade. So using tools to kind of optimize those types of systems has a huge potential. But I think before I get ahead of myself and talk about all the potential, I think one one big challenge we face across globally, I'd argue in pre-hospital care is really the data hygiene of our profession. In many ways, we're a fairly nascent profession, still professionalizing, still carving out our niche within the healthcare system. And our ability to train models or do any kind of advanced, deep learning or otherwise will depend on the quality of our inputs. And I think to my point earlier about us not providing the right tools to our paramedics, simple documentation and note taking is still a challenge. You can imagine the difficulty of working up an arrest in our region on a boat in the middle of the night and keeping good documents. So I think getting better tools in the hands of our medics so they can record more accurate field observations will then inform our models. And I just spoke recently with a colleague at a major North American city who is still working on a paper-based system, and they're frantically digitizing everything to train a model. And so unless we can get our sort of collective house in order and get our data structured and managed, put some hygiene in place, work on our quality, and digitize that information, I worry that pre-hospital will be a little bit left behind relative to some of the other health professions. So that's an area I'm very interested in, and I think some of those archaic practices in our charting will get a lift from AI, but I think it's a bit hopeful to think sprinkling AI dust on pre-hospital will solve all of our problems. We still have to do basic data management, basic data validation, quality work, et cetera. So yeah, I see huge potential, again, building on 80 years of work. And I think really the big potential is that computer-aided human model where it's complementary to the work we're already doing and increasingly just helps with high quality decision making, both in the field and in the dispatch centers.
Yeah, absolutely. Let's just go there for a little bit longer and actually maybe
Mhm.
zoom in on sort of large language models within EPRFs or electronic patient report forms. Could you maybe speak to just or indeed share your mental model about how you see LLMs sort of looking within an electronic patient report form? How would that look?
Mhm. So to kind of unpack what an LLM is essentially a model trained on a large corpora of data. And more, the medical literature is working its way in. And I think, for any of us who've done research in the pre-hospital space, there's a bit of a blind spot around pre-hospital. We don't have a ton of literature. And so that in terms of training our models will be a challenge. But essentially you take these large models and you train a model to essentially recognize patterns and develop the ability to summarize, synthesize information, identify entities, et cetera. Where we're seeing a lot of advances with LLM now is sort of commercial applications people may have interacted with, like a prompt like ChatGPT or Gemini, right? So those behind them have a large language model that's trained to recognize questions and deliver salient responses. So you can imagine that any of these language models can process something like 20,000 tokens per second. So 30 pages of text a second. So if you've got an ambulance service that's on the front lines responding to a mass casualty incident, and you have a tool that can analyze 30 pages of text a second, you've got an edge, right? And if you're trying to make decisions as a dispatcher, running models on a graphics processing unit that can handle 1,000 billion transactions per second, there's just no comparison with our ability to reason and our capacity for intuition. So we will always need humans in the loop, our paramedics and dispatchers, for that intuition and problem solving. And in fact, when we look at fields like chess, where a lot of AI models have been trialed, there's nothing more potent than a human coupled with a machine, where that unity, you kind of offload some of the data integration, the automated analysis, the discoverability, and the machine analysis to the AI, and you free up your paramedic or your dispatcher for interacting with the patient, for identifying subtle patterns, for blending visual and temporal and audio signals to kind of understand the patient's needs. So in that sense, I see AI playing a huge role, but specifically to your question for the LLM and EPCRs, the quality of our EPCRs is a challenge. And I think a lot of our systems we've used are sort of more of a survey tool with a lot of free text. And so we're going to be able to retrospectively extract a lot of knowledge from our PCRs. Things that used to be difficult, like natural language processing, optical character recognition from PDFs, are much easier now. So we can get more of that information out. We can also synthesize and analyze it. And then we can start to work at the sort of public health level and look across our PCRs for trends and patterns in everything from our protocols and procedures and guidelines to outcomes to shift patterns and the workload and burden on our medics and dispatchers.
Yeah, so it is ubiquitous in essence. There's so many different functionalities for AI. Just something you said earlier, Nico, which was super interesting, was really around the work you are doing on differential diagnosis. So I know at the moment with remote CT scanning, AI is embedded within these models so that it can interpret remote CTs and have image recognition and pattern recognition, so that there can be some semblance of recognition of normal versus abnormal. And in essence, as to your point, we've had AI embedded in some which way in a lot of ECG algorithms in the past, Levain and the Glasgow algorithm within the 12 lead ECG interpretation for a number of years now. Again, it's been algorithmic. I'm not sure it's certainly been artificial intelligence, but we have had the support of algorithms for quite a while. I definitely envisage a time, and I'd be really interested to hear your perspectives on this, is when you have a physiological monitor, such as a 12 lead ECG with blood pressure, pulse, and you interact with the screen in some which way to give a picture of what you might think might be wrong with the patient. But do you see a day where the physiological monitor is almost speaking to you, saying, "Look, have you considered these top 5 differential diagnoses based on the physiological monitoring, based on the clinical picture in front of you"? Is that something that could be an emergent reality?
100%. And I think your comment of speaking to you will be a big one. So how we interact with these tools. Yes, we're already using some of them, and we also use Google for diagnostics. But many of these sort of promise a better user experience. And specific to our profession, and when I think to some tech work we were providing during Ebola, the big challenge was for physicians to record their charts in very restricted. So the ability to interact with a machine with voice commands and receive voice prompts back is a major innovation. And I think a lot of the voice recognition advances have come from machine learning and deep learning. And the day of yelling the same command to your phone 20 times to get it to silence an alarm, are kind of behind us. It's moving at a breakneck pace. I think when we talk about the example you gave of an ECG, I mean, step one, back to my data hygiene question, is it still boggles my mind that we print out a paper strip and then lose it somewhere along the way. And when I've met with cardiologists about this topic, they've said that early, image from the field of the heart at the time of their concern is invaluable and can inform their entire trajectory in terms of surgical options and treatment. And so getting that strip to the physician sooner and using some of these technologies to do so, I think is a huge opportunity. And so within that ECG example, there are opportunities for learning and training our paramedics by sort of analyzing a broad variety of strips and providing more interactive outputs like annotated charts showing the different complexes and how they should be interpreted. There's a machine vision component there too, with legacy technologies and charts where we can look at those time series and learn a bit more about our past data. And then there's, when you're coming down to clinical decision making, you get into these interesting kind of rule-based expert systems where we can start to interface some of our practices and guidelines and protocols into that decision support model. And indeed, like you suggest, have the machine prompt you with, hey, have you considered this differential? Hey, have you done a blood glucose on this patient, right? So tying in best practices from paramedicine with your care gives you sort of another partner, if anything, in those really austere settings.
So let's just pivot slightly and look at the interplay between data and equity of care, Nico. Could I get you to speak to that?
Yeah, I think equity is a big one, and I worry that pre-hospital will be a bit left behind in the health equity model because of some of the challenges I've alluded to earlier with our data availability. I think paramedicine's had this funny, tenuous relationship with the rest of the health system. It's sometimes a bit of an unequal footing. It's issues around professionalization. It's a new profession. And a lot of those have kind of left a blind spot in our interpretation of our profession and the availability of our data for informing these models. So there's a simple kind of professional equity aspect there. But there's also, when you think about these models, I talked earlier a bit about bias, and so much of this training is done on largely, Anglo-American EMS systems. It's done for large urban centers, et cetera. So there are these inherent biases in how we return those differentials that may not reflect a patient population we're dealing with in a different region of the world or a different geography within a country. And so in that sense, it's important to bring more parties to the table, to have more diverse inputs into training these models. But then there's with technology writ large, there's an equity problem overall in terms of equitable access to those technologies and equitable access to these technologies by our services, where I don't see quite enough small companies and innovators and access. There are barriers to working with health data, which keep some of the local homegrown tech solutions off the table. So sort of a different twist on equity, but in terms of evaluating a truly performant and equitable system, I mean, it should be equal care available to all. And there are barriers to that have alluded to their social constructs, their public-private barriers, et cetera. And so I think we have a long way to go to realize that kind of equitable care goal.
So looking at the way we kind of leverage data to sort of improve access to healthcare, but also improve the resilience of EMS provision. Something you said earlier around just having, you just mentioned earlier about the disparate, you can move within different various states within North America, and someone's on a paper-based system, someone's on an electronic PRF, someone else is on quite an advanced system. But could you maybe speak to sort of this ubiquity of and just indeed resilience of EMS provision within AI, what it might do to the common standard and indeed sort of the common, I see standard, it's almost the common expectation of where we might be within EMS provision.
Well, in some ways, I think it could democratize the analysis and use of the data. I think it's a challenge for smaller ambulance services to analyze and process their own information. So there is an element in that sort of computer-aided model, which also will inform the design of performance measures and indicators and the availability of that information to leaders, right? I think paramedics are really good at gut decisions. We can walk into a room and say, sick, very sick, pretty quickly, and capturing that with a model or an AI is a bit more challenging. And I think the early versions, I mean, you give a paramedic one of these early differential diagnostic tools, and there will be strong opinions had about how good it is. But in the long term, I think the more we feed into these systems, the more we kind of democratize access to that high level of decision support and can put these tools in the hands, possibly even just off, mobile devices, right? We can put pretty powerful computational power in the hands of medics globally and leapfrog some of the technology barriers we've had up to this point.
So just looking at the way in which future applications of AI feature within the EMS context. So one of the aspects I found absolutely fascinating was when, in not too distant past, was when actually within a dispatch center, we now and have had the capability actually for a while, Nico, of looking at, so enabling the camera phone, and this happens within the UK context at the moment. So enabling the camera phone by sending a text message, you can point the camera phone at a patient, and what the application will do on the software will count the respiratory rate, it will tell you the heart rate, the respiratory rate, and obviously you can get a lot from the palo and from the actual scene itself. But the software will also already start to cleave some diagnostic ability, which is informing the dispatcher, which is then hopefully being transmitted through to immediate sort of some immediate care over the phone, and then also back to the responding crew, which might be, I don't know, 5, 10, 15 minutes away. But could you, I guess my actual question is, the future application of AI within an EMS context, that's one feature in a dispatch sense. Where else can you see, where's the next, literally, what are the short-term gains we're going to see within the next 6 months to a year?
Well, I think the one you've just referenced is a big one. Telehealth really rose to prominence during the coronavirus pandemic. We saw the great potential of expanding the reach of our workforce in a scenario where we had, infectious disease control restrictions limiting our access to our patients, but also a diminished and depleted workforce. And we really just need reinforcements. So being able to have, secondary triage lines and physicians able to sort of broadcast their presence out to the field, particularly in our sort of, Anglo-American model where we don't necessarily have physicians on CAR, we can bring more specialists to the patient, which is a huge opportunity. And having the device also helping collect that data starts to get at this strange phenomenon we have in our profession where we just collect these discrete data points. And then with our big, nitrile gloves, we try to type it into a machine and hope it's accurate. Whereas most of our devices record continuous data, and we should be streaming that into our tablets. There's a simple tech and connectivity barrier to overcome there, but we can also now think about streaming that out. And so there will be some advances and enhancements there with device interoperability and the Internet of Medical Things, where devices and interoperability start to be able to inform a remote physicians more realistically. So that's one area. Another will just be diagnostics in the field. We talked about differential diagnosis. So being able to present a series of plausible diagnoses for a patient to evaluate different care pathways or transport decisions. I think we're also going to see advances in patient technology. So our patients will be informing themselves about their conditions with AI using online prompts. And so they'll have a different kind of vocabulary in how they describe their condition and their concerns about different diagnostics, as well as wearing devices. So patients with devices, one thing to connect with our own devices, but at some point we're going to want to pull data from patient devices, right? So if patients are wearing a heart monitor, if we've been alerted to their fall by an automated fall algorithm, there's a lot of area for support there. Dispatch will be huge. I mean, dispatch, ton of respect for dispatchers. It's a complex trade. It's a mental gymnastics in every sense to understand the logistics, the resource profiling, all of the considerations that go into dispatching the best available resource. Um, Ambient scribes and note-taking, we talked about that a moment ago. I think the difficulty of entering good data in the field, is one where having an ambient scribe recording information, synthesizing it, and helping you with your handover notes is a big one. What else? So we'll see on our patients sort of more social and physical assistance systems. So we've seen improvements in drug adherence in our patient populations by providing them with an AI avatar. So someone they can talk to for medical advice, and that becomes part of the care team now, right? And we need to think about how that affects our actions in the field. More examples, I guess patient safety is a big one. So just having that second opinion, you count on your partner often, say, hey, I'm about to administer this drug. These are my 6 rights. Having, an AI be able to read the barcode and say, oh, wait, that's expired. Or, that's contraindicated based on their chart. Hey, I just pulled their chart from the central system. And then a big one, I think, really in terms of making these tools usable is the interface. So AI is being used to improve user experience with devices. That includes our charting software, but also some of the speech recognition we talked about earlier, both the ambient scribes and the ability to interact with these technologies to ask questions and receive timely answers that are suited to a setting like the pre-hospital setting.
No, that's fantastic, actually. And one of the aspects that you just mentioned there around note taking and just capturing that information through transition of care. I was privy to some research which was ongoing around how much humans actually retain or don't retain from a handover, especially from a sort of a trauma handover or a sort of a pre-hospital alert. And because there's so much activity and you might have an actively dying patient and there's lots going on, it narrows the bandwidth as well and narrows the ability just to remember salient information, let alone diagnostic points. So one of the things I was really quite fascinated, a couple of initiatives which are ongoing at the moment is this virtual ward concept where there is these virtual wards already ongoing where patients are being monitored 12, 24, 36, 48 hours in their own home, but virtually. And then another one was this transition of care whereby there's initiatives going on at the moment whereby there's a 32-inch screen above the bed in a trauma bay, and that the handover information is captured there. The salient handover might be Atmis Stambo, might be SBAR, but that chunked information is captured on that screen, so people can just look at we know there's going to be information entropy, but that transfer of data and information has already been passed from the pre-hospital crew through AI or indeed just through just voice to text, and then that's been transitioned through to a big 32-inch screen across the trauma bay, so people can just look up, remember what the main pathology is, remember what the SBAR is, the situation background assessment recommendations, and it's captured there. So it's pre-existing and it's future existing, so that whatever's happening around the patient, there's a central point of focus and of truth, single point of truth above the patient. And anyways, that's a bit of a brain splurge, but that's what I envisage.
No, and you're spot on, and I'm seeing that in the work we're doing with rural physicians and telehealth systems, where generating SOAP notes, the physician equivalent, sort of the salient points extracted from the chart, is so helpful. And I think hurtling off to a hospital, you've got a complex trauma, you're trying to manage the patient, yet you have to get on the radio and notify the receiving hospital and remember your ISPAR, your Atmis Stambo, or whatever models in your head, and get all of the essential points across, so they assemble a trauma team. And if you can offload some of that and help with task saturation in our paramedics, there's huge potential of really complementary role for these technologies. So we're seeing it in reducing administrative burden on physicians of generating those type of notes, but then it's also that sense of being able to project it forward and notify relevant crews, or even for supervisors to be able to be aware of significant events, right? So having automated alerts come to them that maybe your crew needs a hand, maybe they need another resource or unit, and they're so task saturated they haven't been able to get on the phone or even have the connectivity in some of our rural areas to realize that. So yeah, that's spot on. And I do think that the handover, the transitions are really a keen point of failure. And I would say not just between EMS and emergency departments, but also our interactions with first responders and fire departments. I've been doing a lot of work recently with fire departments around the first responder role here, and it's a huge workforce. They're often first on scene, and there's sort of a necessity to integrate them into the care pathway as well and help support some of those handovers. And the ambulance crew should be receiving early notifications from those FR units on scene. So I think across the whole emergency services system, there's a lot of opportunities for streamlining communications.
No, listen, that's fantastic. So a couple of things as we come into land, Nico, and it'd just be really interesting whilst I've got you just to pick your brains on. One of the biggest risks within pre-hospital care, and not just pre-hospital care, it's across the system, actually, across the healthcare system, and it's the unspoken risk, really, of fatigue. Fatigue over enduring day shifts, night shifts, late shifts, early shifts, weekend shifts, and just that the chronic fatigue which builds, and that actually bleeds into decision making, bleeds into information retention, bleeds into lots of the ways in which we interact with patients. How, and again, this is maybe a question I'm hoodwinking you with and haven't, but it's something which is definitely front of mind from a human factors perspective. Do you foresee sort of AI facilitating and or supporting or holding some of that risk for fatigue management?
I do. I think, to manage that, we do need to improve the quality of our data because, of course, as fatigue sits in, our data quality decreases. We put a huge burden on our paramedics and dispatchers to work quite long hours in very challenging settings, and we're not providing adequate technology support to help combat things like burnout, mental health, and moral injury. And some of these tools can be equally as good at, helping with that clinical decision as they can that scheduling decision, or identifying a crew who might need to speak to some peers after a particularly difficult call. And so pulling out and looking at the perspective of your workforce management and thinking both of patient safety and your staff safety, and leveraging tools that can help manage that burden, help introduce best evidence-based practices in shift scheduling. And fatigue is not just, it's in the immediate moment of your crew, but also, being in those alpha patterns, going out day and night, doing dozens of repetitive calls, has long-term effects, and we know that. And so helping to manage those and cycle the workforce through different roles, and adequately manage our crews, I think is an area that AI may be able to help, even as a prompt or something to talk to get more advice. And in those fatigue moments, that second opinion could be a game changer.
So just finally, Nico, as we finish off, could you speak to any take-home messages just for clinicians that they should be aware of within the AI space?
Well, it's moving fast. And, I think about just my own models that I've been training here, and I've cycled through 3 in 2024 sort of neural nets that are working behind the scenes. So, I think it's also inevitable. It's going to impact our practice over the next few months and years. And like any new technology, there are going to be hiccups and there are going to be challenges. I think the onus on us, we are all professionals. Many of us, practice independently within our jurisdictions, and we are our own licensed paramedic, and we sort of have an onus to try to keep up with some of these technologies and trends. But also an opportunity to do that is to get the help of AI to monitor AI. So thinking about using prompts like ChatGPT or Gemini, or some of the hardware accelerated prompts on Grok with a Q that presents different models like the Llama model, and new models like Claude from Anthropic that a few weeks ago showed some sort of self-awareness in realizing that a string of text embedded in a massive corpora had been put in there to test it. And it said, hey, am I being tested here? So, when AI is getting to that point of graduate and undergraduate level reasoning, they're an invaluable partner for us as clinicians. We can help keep up with the literature. We can help keep up with best practices by querying, those prompts. I think, we'll see a lot of emergence of these tools in our dispatch center. The improvements around voice recognition are one to look out for your charting and note taking. And then I think it's going to be bumpy, I think, over the next but there is tremendous opportunity, but there's also a tremendous need for ethical oversight, regulatory oversight, et cetera. And our institutions are going to have a hard time keeping up and catching up. And in many ways, I'd love to see some of these tools rolled out, but in other ways, we have an obligation to protect our patients and our crews and privacy and all of these other key considerations in the health sector. So while the coolest tool may be on your phone today, it may be a little while yet before it's on the car. But being aware of those and learning how to use them and integrating them into your practice, I think could help clinicians stand out and really advance sort of their reflective practice.
Nico, listen, that's fantastic. Absolutely fantastic. One of the two things we're bumping up against at the moment is this data sovereignty perspective. And, just where if data is created in a place, who owns that data? Is it owned locally, or is it owned in a remote place, and what's it used for in a remote place? So I think you're right, and all these kind of issues are coming to the fore, and we're going to have to really interact with them and understand what the new baseline is. What's the universal baseline of acceptance for these tools. Thank you so much for the last hour. Really, listen, Nico, it's been hugely interesting and engaging just speaking to you. So I really do appreciate just your thoughts and perspectives. Thanks, Nico.
Well, thanks so much. I appreciate the insightful questions. And as always, enjoy listening to your podcast. And thank you so much for having me on.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.